So I call upon Dinu Abhirami for review of Indian literature.
Good evening, everyone. I'm Dr. Dinu Abhirami from Global Hospitals, Chennai. I'm going to review about the Indian literature on chronic pancreatitis under the guidance of Dr. Mahadevan. I would like to thank all my teachers for guiding through my presentation and for TNISG for giving me this chance. So this is the agenda for today. We're going to discuss about the epidemiology, etiology, genetics, clinical profile, complications and management. So we know chronic pancreatitis is basically an inflammatory process resulting in fibrosis and calcification of the gland. So this is the history. The first report from India was in 1937, followed by 1962 there was a case series from Kerala showing that chronic pancreatitis was more presenting in childhood with diabetes and the death was early in onset. So if we see the global distribution of chronic pancreatitis, in Asian countries it is more common in India and China, and worldwide prevalence reported is 9.6 per 1 lakh population. And from this study we could see the comparison across countries. India, a study reported in 1994 showed that the prevalence was almost 126, which is very high when compared to other countries, both in the Asia Pacific and all over the world. So this was the first prevalence study from India showing the prevalence of chronic pancreatitis to be 1 in 793, which is actually a population-based study. And based on this, the Asia Pacific survey showed that the prevalence was 114 to 200 per 1 lakh population. So age of onset of the disease, I have compared data from various studies across India, and almost all studies scored the age group between 30 to 40 years of age. And in this study there was a bimodal distribution of the disease, and they have subclassified it as idiopathic pancreatitis being more common in the second decade and alcohol related chronic pancreatitis more common in 30 to 40 years of age. So comparing male to female ratio, across studies it has been shown that the male population was 2 times or more higher when compared to the female group. And from all the studies we conclude that there is a higher incidence in males when compared to females, that is twice as high in males when compared to females. So across socioeconomic status, we could see that it is more common in the lower socioeconomic groups. Moving to the etiology of chronic pancreatitis, this is a study starting from 1962 until date. Initial studies were more on tropical calcific pancreatitis. In 2000, even till 2004, studies scored 70% incidence of tropical pancreatitis, whereas recent studies, if we see the incidence of alcohol-related pancreatitis and also the other etiology like biliary, genetic and also autoimmune pancreatitis are coming up to be reported. So across countries, if we compare the etiology, tropical pancreatitis was most commonly reported from India and China. So this is a comparison of studies in India from 1962 to 2009, which I have already shown that idiopathic pancreatitis was initially more, and recently the alcohol and idiopathic chronic pancreatitis have been almost similar. The incidence have almost been similar. Next we'll move on to genetics involved in chronic pancreatitis. Actually there is more literature of genetics in idiopathic recurrent acute pancreatitis. In chronic pancreatitis also a few genetic factors have been identified. This is the HLA predisposition. Lot of HLA predisposition has also been identified in chronic pancreatitis. And we classify these genetics in chronic pancreatitis into trypsin related, non-trypsin related and also pancreatic duct related, which are more often to deal with the cystic fibrosis transmembrane receptor gene and also the calcium sensing receptor genes and few other ion channels. So these are studies from India showing the genetics in chronic calcific pancreatitis. Across studies we could see that the incidence of SPINK1 mutation, CFTR mutations were more in Indian population. That is, it was positive in 23% of patients with idiopathic pancreatitis when compared to 2% within the control group. So from this study also we could see that in India SPINK1 mutation was 40% and CFTR mutation was 9%. So recently there are a few other genes coming up. This is a claudin gene to deal with the tight junctions in pancreas, which is also considered a predisposition both in alcohol and idiopathic pancreatitis. And also this MOR-C4 gene, which is to deal with the ATPase activity. So this is a recent paper from January 2023 showing TRPV6 gene. It is actually a calcium channel related gene which is involved in the pancreatic duct, and this gene has also been, novel frameshift mutation in this gene has also been found to have a predisposition for hereditary pancreatitis. So idiopathic versus tropical pancreatitis. Is it still an enigma? Previously, they named it as tropical calcific pancreatitis, and current studies name it as idiopathic pancreatitis, chronic pancreatitis. So there have been a lot of literature on this, letters to the editor on this topic, ICP versus TCP. Tropical pancreatitis, why it was considered a distinct entity was because it had a younger age of onset, it had more of calcification in the pancreatic duct, and it had an accelerated course of disease with high susceptibility to pancreatic malignancy, and almost all patients had pancreatitis related diabetes. So this is actually from AIIMS Delhi, which has shown that only the nomenclature has been changed, whereas the etiology, previously tropical calcific pancreatitis was considered to be related to malnutrition. Malnutrition was considered a cause of TCP, but now it is rather considered an effect of TCP rather than a cause. And also there has been an improvement in the prognosis in recent idiopathic chronic pancreatitis, and also the risk of malignancy is less in recent population. So moving to the clinical profile, across studies, the most common presentation of chronic pancreatitis was with abdominal pain, reported in almost 90% patients, and the next common feature was endocrine insufficiency resulting in diabetes. The other clinical features were they present with jaundice due to benign biliary strictures, exocrine insufficiency resulting in steatorrhea, vomiting, a lump in the abdomen, GI bleed, which is due to vascular complication of chronic pancreatitis, and with weight loss, ascites, and in one study asymptomatic chronic pancreatitis detected incidentally on CT was almost 16%. So there has been a lot of changes in the age of onset as well as the etiology in comparison to previous days. That is, in the beginning of 21st century, this is a paper from Kerala showing the comparison of groups between before 2006 and after 2006. We could see that the age of onset has shifted by nearly 10 years, that is a decade later the age of onset was, and also the etiology is alcohol related chronic pancreatitis is coming up. So this is the change in clinical profile in chronic pancreatitis. Lot of articles have been published on this. So why there is a change in clinical profile? This has been described in various editorials as well. This is the shift. There is a shift in age of onset a decade later, that is 10 years later. The clinical presentation in recent times is heterogeneous. Previously they used to diagnose only at the stage of endocrine insufficiency. The classical picture of TCP is seen only in 10 to 15% cases in recent times. And the etiology, there is increased incidence in alcohol, because of the increased incidence of alcohol consumption and smoking, the etiology of alcohol related chronic pancreatitis is coming up. So the possible reason is a change in environmental, dietary as well as lifestyle factors. So comparing alcohol versus idiopathic chronic pancreatitis, we already know that idiopathic pancreatitis has an earlier age of onset. I'll summarize the findings alone. So idiopathic versus alcohol, the age of onset is younger in idiopathic or tropical pancreatitis. They are more malnourished when compared to alcohol related. Diabetes is more common in tropical pancreatitis. Pancreatic duct is markedly dilated, and if we see the calcifications, they are dense, large and discrete calcifications involving larger ducts, whereas in alcohol it is fine speckled calcifications involving the parenchyma or the smaller ducts. And the course of disease is rapid with increased risk of malignancy in idiopathic or tropical pancreatitis. So coming to the complications of chronic pancreatitis, across studies, the most common complication reported was endocrine insufficiency, followed by pseudocyst of the pancreas and exocrine insufficiency. Neoplasms of the pancreas, the incidence is less than 10%. Most studies quote it to be less than 5%, that is 2 to 4%. Comparing the complications between alcohol versus idiopathic chronic pancreatitis, there has been found to be no difference in the incidence of complications. So, what is the natural cause of chronic pancreatitis and what are the risk factors for pancreatic malignancy in patients with chronic pancreatitis? This paper has shown that out of 1057 patients, 70 patients developed malignancy, and out of them 85% were idiopathic. The background was idiopathic chronic pancreatitis, and in 14% it was alcohol related. So the prevalence of pancreatic malignancy in chronic pancreatitis was 6%. It was more with the idiopathic group when compared to the alcohol related group. Moving on to evaluation in chronic pancreatitis. Initially, the exocrine pancreatic function test, direct pancreatic function test studies were being done, in which 15 patients were involved, and out of which they found that the protease and lipase activity was much less in the duodenal aspirate when compared to the amylase activity and bicarbonate activity. So, protease and lipase were considered more sensitive for direct assessment of pancreatic function test according to this study. Next, comparing fecal elastase versus a 72-hour stool for fecal fat estimation. This is from study from CMC Vellore. Comparing the cutoff of fecal elastase a bit less than 100 and less than 200, we could see the sensitivity is more with more than 200, but specificity is only 10%. So, fecal elastase, it could be used as a good screening test, but it is not diagnostic. It is only it has a supportive role in chronic pancreatitis. So, a correlation of imaging findings with exocrine insufficiency in chronic pancreatitis. Out of 70 patients, this was a correlation. Most commonly it correlated with parenchymal calcification and with the intraductal calculi. So, currently we know that CT, MRI are routinely being done in diagnosis of chronic pancreatitis. Currently the role of EUS has taken up in chronic pancreatitis. This is a study from Delhi, multicentric study showing they have compared the EUS findings with the CT, and they have shown that all these findings in EUS, that is hyperechoic foci with shadowing, lobularity with honeycombing, and main pancreatic duct calculi, irregular PD, thickening, hyperechoic duct margins, all these were statistically significant, and these findings were found to have a good correlation with those who had findings of chronic pancreatitis on CT. Next is a predictor of malignancy in chronic pancreatitis with a head mass, whether it is an inflammatory mass or a malignant mass. This was actually confirmed with the excision, that is after surgical excision. This is a study from Stanley. It has included a total of 60 patients, and it has included a total of 83 patients, and they have found that out of which bilirubin cutoff of more than 5.8, CA99, elevated CA99, dilated MPD and dilated CBD. These were the statistically significant predictors of pancreatic malignant pancreatic head mass. So, moving on to management in chronic pancreatitis, I would cover up a few topics. First is role of nociceptive analgesics involving nociception, that is a combination of pregabalin with antioxidants versus a placebo. This is actually an RCT. This has shown that there was a statistically significant percentage reduction in the visual analog score in patients who received the antioxidant plus pregabalin group when compared to the placebo group. Role of antioxidants per se. This is a study from AIIMS Delhi, which in 2009, this is actually an RCT involving 70 patients in the study group and 60 patients in the placebo group. They have used a combination of organic selenium, ascorbic acid, beta-carotene, tocopherol and methionine. So if we compare the placebo as well as the study, that is intervention group, there has been a statistically significant reduction in the painful days, and also there has been a reduction in the use of analgesics. The requirement for analgesics was also less in the treatment group when compared to the placebo group. So this study has suggested that antioxidants do have a role in pain management in chronic pancreatitis, whereas this is a recent systematic review and meta-analysis involving RCTs across the world. This is from published from India. Actually, in this, two studies were Indian studies. RCTs from India were two, and this study has concluded that only in a subgroup of population, that is in Indian study, it involved more of younger patients and more of idiopathic chronic pancreatitis. Only in a subgroup of patients, this antioxidant has a role, whereas it is the role of antioxidant in pain relief in chronic pancreatitis could not be generalized. The role of pancreatic enzyme replacement therapy. This is also an RCT using 40,000 units of entry-coated pancreatin in exocrine insufficiency, and this is actually multicentric study. This study has shown that there has been a significant improvement. Actually, the patients were treated for 51 weeks, and at the end of 51 weeks, almost all patients had statistically significant improvement was seen with stool consistency. There was reduction in the abdominal pain, and also the quality of life was there was an improvement in the quality of life. So a few patients, a subgroup of patients do not respond to this PERT therapy. This is a study from CMC Vellore, which has shown that chronic pancreatitis patients do have a predisposition for small intestinal bacterial overgrowth, and in those patients who do not respond to PERT therapy and still have symptoms of diarrhea and steatorrhea, they should be checked for SIBO, and they have found that almost 1/3 of patients were proven to have SIBO based on jejunal aspirate. Moving on to endotherapy, we have multiple options in endotherapy. First is role of ERCP and ESWL in pancreatic duct calculi. This is actually an abstract. I could get only the abstract, which included 525 patients, out of which we could see that pain relief was seen in almost 98% patients with endotherapy, either ERCP or ERCP combined with ESWL, and also they had a significant improvement in their sustained pain relief over the next 3 years was achieved in 82% patients with an improvement with a weight gain, and also the requirement of insulin also came down in almost 35% patients. The complication rate reported in this study is 16.5%. So this is a study comparing the various interventions done for chronic pancreatitis published recently. So this study has included 67 patients, and after endotherapy there was a statistically significant reduction in the visual analog score. However, HbA1c and fecal elastase were not that significant. So if we see the intervention, the complete PD clearance was achieved only in 62.7% patients, whereas pain relief was seen in 77% patients. So intense pancreatic endotherapy is currently considered safe and effective in patients with chronic calcific pancreatitis. Next is impact of ductal intervention on diabetes. We know that pain relief is achieved with the endotherapy. The role of ductal intervention on diabetes in patients with chronic pancreatitis. We could see from this study has included 644 patients, out of which the diabetes free interval was significantly longer in patients who underwent ductal intervention. So not only in pain management but also in delaying the onset of endocrine insufficiency, this interventions would help. And this is paper quoting endotherapy for pancreatic duct stones. They have graded based on the severity. That is, male pancreatic duct stones without any complication like a proximal pancreatic duct stricture or a mass lesion had better outcomes with pancreatic endotherapy. This is from AAG showing the role of extracorporeal shockwave lithotripsy in almost 5,000 patients they have done. And most common indication was a pancreatic duct calculi more than 5 mm in the head or the body region, which is not amenable to endotherapy, and the patients presenting with abdominal pain. So if we see the pain score, there was a statistically significant reduction, and also the use of analgesics was less after ESWL in patients with pancreatic duct calculi. The response rate quoted in this study is 95%. So this is actually an RCT which is being it is currently going on for ESWL in chronic pancreatitis. Next is specific management. What are the role of interventions in pancreatic divisum? So this study has actually included 47 patients, out of which 45 patients had a successful outcome after a pancreatic duct stenting. 45 patients became symptomatic in chronic pancreatitis who had associated pancreatic divisum to be the underlying cause of chronic pancreatitis. Benign biliary stricture in chronic pancreatitis, a comparison of metal stenting versus plastic stenting. Both were equally efficacious according to the study, but the number of ERCP sessions were less with metal stents when compared to plastic stents. It's actually an RCT from AAG. So endotherapy, the response rate of endotherapy quoted is 60 to 70%, whereas with surgery it is almost 90%. This is for both short-term relief and for long-term relief. It is almost 70 to 80% after a surgery for pain relief. So moving on to few surgical procedures. Ductal drainage with the head coring in chronic pancreatitis for small duct disease. This study has included 45 patients and it has compared between a small duct disease versus large duct disease. There was no significant difference between the two groups, and the pain relief rate was almost 90 to 94% in small duct disease and 91% in large duct disease. The complication rate was 15 to 18%. And this is a comparison of the various surgical interventions done for chronic pancreatitis. The most commonly done intervention was a Fraze procedure, followed by longitudinal pancreaticojejunostomy. And this has shown that the pain relief was almost 90% with Fraze procedure, and the quality of life improvement was very good with Fraze procedure. So to summarize, we have seen about the change in spectrum from the after the 21st century, tropical versus idiopathic chronic pancreatitis. The increased recognition of genetic factors and genetic predisposition coming into role recently. Evaluation, it is mainly based on imaging and the role of EUS in evaluation of chronic pancreatitis. Management, we have seen about antioxidants and PERT therapy. And also regarding endotherapy and ESWL in special situations and surgical management. Thank you. I'll just discuss two more slides. So in pregnancy, this is a recent article from CMC Vellore showing pregnancy outcomes in patients with chronic pancreatitis. They have shown that the presence of chronic pancreatitis, that is early onset chronic pancreatitis, does not influence the pregnancy outcomes in patient does not influence the pregnancy outcomes, and they have been found to have a normal course as other pregnancies. And as intestinal microbiota comes into play everywhere, this is also a paper showing that In chronic pancreatitis also, in onset of diabetes and metabolic abnormalities, there is a change in the gut microbiota in patients with chronic pancreatitis, and this needs further research. Thank you.